Welcome to Variations 4, the pH and Lytes unit, covering questions 21 and 22. This is talking about serum potassium. So 21, where in the body, just some basic questions about potassium. Where is it and what are its functions? 22 is going to ask us to talk about increased levels and decreased levels of potassium and some discussion around that. So we'll approach both those questions right now in map 7 and 8. So where is potassium? We know potassium is inside and outside the cell. But where is the greatest concentration of potassium when the body is in homeostasis? The greatest concentration of potassium is in the ICF, that is inside the cell. All right, functions. Can you list 5 functions of potassium? These first 3 here, nerve impulses, cardiac rhythms, muscle contractions. So neuromuscular function, cardiac rhythms. I think we can take a lot of the electrolytes, magnesium, calcium, potassium. We can throw a lot of them in, even sodium, especially with your neuromuscular. You take any of those, you raise them up high enough, you bring them down low enough, and you're gonna have neuromuscular, cardiac arrhythmias, dysfunctions in all those areas. That being said, potassium is always the first one that comes to mind when we think of cardiac arrhythmias. And why is that? The reason is that if you look at your normal range of your different electrolytes, you'll see that there's some pretty large numbers for most of them. You know, in the hundreds, say. Potassium, it's a very low number. Depending on what textbook you read, it's only like 3.5 to 5.5 millimoles. Not a whole lot of give. And so it doesn't take a lot of changes in electrolytes for us to start worrying. Sorry, it doesn't take a lot of change in potassium for us to start worrying about cardiac arrhythmias. And that's why potassium is the big one that comes to mind when we think of, hey, if you mess around with your electrolytes, which one's going to, when are you going to be doing an ECG with which one of these? The reality is they could all bring us to that point, but potassium is particularly sensitive because it doesn't have a whole lot of wiggle room like the other ones have usually much higher units to play with. Okay, acid-base balance, the fourth one. We're going to talk about potassium's role in acid-base balance and how that kind of plays out later on in this unit. That'll be in another video. ICF osmolality. Can you explain that? Can you compare that to the sodium osmolality? Compare and contrast potassium osmolality, its role in the ICF, with sodium osmolality in the ECF. I've kind of answered half the question already within the question. The question being compare and contrast the osmolality functions of K and sodium. Well, we just talked about how sodium plays through many different scenarios in terms of fluid shifts outside the cell. When sodium is at a healthy level, it helps to keep water in the vascular space. It's got oncotic pull. Potassium does the same thing inside the cell. Although there's both sodium and potassium inside the cell, there's greater concentrations of potassium inside the cell. And so it's the player that's really holding the fluid inside the cell, or one of the key players. All right, so the next question wants us to talk about increases in serum potassium. Now, if you read through these rectangles at the top, some of them are going to be very obvious. Obviously, diuretics nothing more needs to be said. Ingestion and intake via IV or GI tract, not much more needs to be said. Renal failure, a bit of a wild card. We can see Lytes going up, we can see Lytes going down. Sometimes the kidney holds on to things, sometimes it dumps things. It's a wild card, but it's not too hard to understand. Acidosis, hold that thought, coming up in a later video. And aldosterone, well, what does aldosterone usually do to potassium? It usually kicks it out of the body. So if we have a low aldosterone level, then naturally the body would be holding on to more potassium. So it could contribute to a rise in serum levels. There's probably the biggest symptoms we worry about. And what do? The circle is like, what do we do as a medical team with increased serum potassium? The first one here is pretty obvious. Changing your diuretics is pretty obvious to something like, well, don't use spironolactone because that's a potassium sparing. So maybe, I don't know, move to Lasix. K-exolate is a very not so tasty med that patients ingest orally and causes potassium to be lost through the GI tract. Dialysis, not much more needs to be said there. Resolve the acidosis. Why is that? Hold the thought. We'll talk about acidosis later. In the short term, though, insulin will help carry potassium inside the cell again, lowering serum levels. But we'll come back to the acidosis thing later. Calcium gluconate doesn't really have anything to do with lowering serum K. Calcium gluconate has more to do with decreasing cardiac cell excitability, so that if you're worried about arrhythmias, you want to decrease arrhythmias, this might be given. Okay, and finally, same discussion around low serum potassium levels. Not a whole lot of discussion needed on these ones here. These first three are pretty obvious. You know, huge losses from the GI tract will lower K. We know that already. Alkalosis, save that thought for a later video when we talk about pH. Renal losses discussed. Diuretics discussed. Aldosteronism, we get it. Talked about it before. And of course, ingestion issues. Okay, so this whole top part here is fairly obvious, except for acidosis, which we'll talk about, or sorry, pH stuff, which we'll talk about later. What do we do with decreased serum K? Okay, so the last one here, treat the underlying cause. So yeah, I mean, if it's alkalosis, we'll have to treat that. Again, we'll talk about that in a bit. Your diuretic, you may want a K-sparing diuretic. Diet and ingestion and IVs, pretty obvious stuff. And we see this a lot on our general surgical wards. We see patients, especially on a GI unit, getting serum potassium because they usually are either vomiting a lot or putting out a lot of stool one way or the other. Yeah, I mean, maybe in ICU you see more of the acidosis, alkalosis stuff, but for us, it's usually GI losses on the surgical wards. So we see this quite a bit, intervention number one. That concludes the video on potassium.